what do you think of this idea then that we should use techniques to look at the karyotype, for example, and take out cells and use sky imaging or another form of imaging to look at the cells that have an abnormal amount of chromosomes and try to screen for cancer based off that idea?
I like that idea a lot. I think we need to look for some of these initial chromosome breakage and fusion genes that get formed and look for products of them and use that as a way to screen for the earliest genetic events. We already know in breast cancer, for instance, that we have drugs that may prevent a lot of breast cancers, but we don't know who are the women who are high risk who need it and which ones would benefit. And if we had targets like this that we could screen for, we could very quickly determine who needed what drugs or who needed what prevention technique to actually prevent the cancer.
Excellent. And going on that note, tell me about your work with breast cancer patients. How do we detect breast cancer? What are the screening methods currently employed to detect breast cancer?
Unfortunately, our most effective screening tool is a tool from the 1960s, which is mammography. Mammography in women over age 50, if done on an annual basis, reduces the death rate from breast cancer by 1/4. There are two ways to look at that. That is, that's a great advance over not doing mammography. The other way to look at that is 3/4 of women who are going to die of breast cancer will have their cancers found some other way than a mammogram. And it's not going to make any difference what the mammogram sees. That's pretty disappointing. And we, in spite of 30 years of vigorous, aggressive mammography and imaging research, we've got no imaging technique that does better than that. That is a pretty sad story. And it wasn't until the increased number of breast cancers identified at less than 10 millimeters in size began to increase, and that was 1996, that we began to see a nationwide effect of mammographic screening on decreasing deaths from breast cancer. Unfortunately, probably between 1996 and 2000 and 2001, we've reached about the maximum we're going to get from mammography. And that's why there's always a lot of hand-wringing in the breast cancer community about mammography. It's certainly not the screening tool that we want for the next 50 years. Since 2001 to present, the last decade, we've seen lots of improvements in treatment and in prevention, and those are beginning to really pay off now in improving breast cancer survival and outcome. Unfortunately, the other methods of screening are all dependent upon symptom and physical exam. And unfortunately, all too often, those cancers are found bigger than 10 millimeters in size, where it doesn't make a lot of difference whether you find the cancer at a dime size versus a quarter size. It doesn't change the prognosis that much.
What are some of the characteristics? I know you've already spoken about this. What are some of the characteristics that you detect through mammography that can tell you what options are best via the specific type of cancer?
Really, mammography is looking for two things. One, evidence of scarring. About 90% of breast cancers elicit scarring within the breast. So if you can see architectural deformities or masses related to scarring where there's more water-filled tissue than surrounding fatty breast tissue, then you can identify a mass or something that may be suspicious. That's one of the reasons that mammography gets better as you get older. You have more fat, less water-filled tissue, so you're able to see through the breast well. In a 20-year-old, there's a lot of water-filled breast tissue, so it doesn't show up much contrast to scar-related things within the breast. The second thing found on mammography is calcifications, microcalcifications. Microcalcifications form anywhere in the body in response to inflammation. And one of the things that causes inflammation in the breast can be blockage of some of the breast ducts from things growing within the breast ducts or things making fluid within the breast ducts. And both of those things can give rise to calcifications, and that then tips us off that there's something we need to check into further. So those are the things we're looking for with a mammogram. Unfortunately, even under the best of circumstances, the average earliest that you will find a breast cancer is about 6 millimeters in size, and that only gives you about a 14 to 16 month lead time bias over clinical exam and symptoms before the patient and the doctor would have found the cancer anyway. And we believe most breast cancers may be anywhere from 5 to 20 years in evolution. That's a long time with a normal mammogram, and a short time between when the mammogram's abnormal and when you're actually going to have symptoms that would bring you to the doctor anyway.
How do we make a better technique to screen for breast cancer? How do we make it more precise so we can detect it at earlier stages? Do you have any thoughts regarding this?
I'm one of a group of researchers that for the last decade and a half have been looking extensively at the breast ducts. Since 90 or 95% of the breast cancer starts within the ducts make small droplets of fluid, and you can get some of the droplets of fluid out to the nipple with a nursing pump. Is there some way that we could, for instance, with molecular techniques, identify women who are having the first genetic changes within the breast that may mark them at risk for breast cancer, and intervene and try to stop those long before a cancer ever develops? I would say we're still trying to find and identify what are the appropriate early genetic targets to be looking for, and how do we do this when we may only have 5 or 10 microliters of fluid. Those are some technical things, but I think there's a very good chance we may overcome the technical challenges in the next few years.
There's a lot of debate going on in the breast cancer field about lupectomy and mastectomy and whether they're needed or not. Could you speak about what these techniques are and what your thoughts are on when they're required in regards to a specific type of cancer?
Okay, well, lumpectomy and mastectomy, it's good to take a really long-term historic focus at where we've come in breast cancer. So I'll take us back a little bit. The first medical treatise talking about how to manage breast cancer comes out of the ancient kingdom in Egypt, the old kingdom in Egypt, and it was translated in the late 1800s using the Rosetta Stone. And what it said was, in essence, when you have a cancer in the breast, as long as the glands underneath the arm or the lymph nodes are not swollen, you can cure some of those people if you take a hot poker and burn the tumor back to a distance of the width of a dung beetle's back beyond the tumor. The width of a dung beetle's back happens to be 10 millimeters, and guess what? Most people doing lumpectomy today are trying to take out the tumor with a rim of 10 millimeters of normal tissue in all directions. So one of the first things is that history tends to repeat itself. Now, by sort of 100 AD, Galen, a Roman physician, had decided that melancholy was the cause of cancer and wrote a treatise, Carcinogenica Melancholia. He proposed that you should treat the cancer with a variety of herbal teas, one of which we would know today is St. John's wort, because if you could resolve the melancholy, you could take all the evil humors out and prevent people from dying of their cancer. That didn't work very well, but it was the mainstay of treatment until the mid-1800s. And in the mid-1800s, a Viennese surgeon by the name of Billroth, who's known for a lot of GI surgery stuff, proposed that we should go back to a lumpectomy with a 1 centimeter rim of normal tissue in all directions and take some lymph nodes underneath the arm, and that would cure women of breast cancer. Unfortunately, about 80% of women had cancer recur within the breast within 3 years. By the end of the 1800s, William Stewart Halsted, who was the first chief of surgery at Hopkins, had identified that mastectomy could cure women if the nodes were negative. It didn't cure all women, but it could cure a large percentage of women if the nodes were negative. If the nodes were positive, the disease was already beyond the breast, and the chance of curing the women